Okay, so we're going to kick off, I think. I'll just introduce myself for anyone who doesn't know me. I'm Sarah Morgan, GP in Camden at the Hampstead Greek Practice. I'm also the chair of the Camden Training Hub, who has responsibility for education, training and workforce locally. And I'm also the clinical lead for the NCL-wide training hub that's sort of overarching and interfaces with the NCL, CCG and Health Education England. So I have the merry task of talking about some of the common ear complaints. And I suppose I need to put a disclaimer out there first of all. I am not an ENT specialist, but what we're really covering today is what we do in general practice. And as a pretty old GP, I'm quite experienced in that. I have, though, done some work with Mr. Mann, one of our local consultants who's based at the Royal National Ear, Nose and Throat Hospital. He also does some sessions at the Royal Free. And so have been working with him on things like the rhinitis pathway. Look at the middle photo, that person doing their drops. Are they doing it right or are they doing it wrong? If you want to put in the chat what you think, but we'll be covering nose drop administration, because that's one of the reasons why nose drops don't work, or nose sprays rather, because people are using them incorrectly. Well done, Karen, right answer, he's doing it wrong. So anyway, next slide, please. So I did want to just highlight this pathway that is on the Camden GP website. It's the rhinosinusitis pathway. It's got quite a lot of information there, which I will be coming back to a bit during this presentation. But what I find quite useful is just knowing things like the steroid drops that you can escalate management to is quite useful there. So I just wanted to flag that I think this is quite a useful pathway that we have got on the website, and Mr. Mann was very instrumental in creating this pathway. Next slide. So starting off with rhinosinusitis, you can't actually have sinusitis without rhinitis. You could technically have rhinitis, inflammation of the nose, without sinusitis. But what we're talking about is that inflammation of the nose and the paranasal sinus mucosa. So in adults, the definition is that you would have nasal blockage or nasal discharge with either facial pain and pressure, and you may have an impact on the sense of smell. In children, it's slightly different, the definition, because they also include the presence of a cough can happen with rhinosinusitis as well. And when it's less than 12 weeks, it's classified as acute. If it's been going on for more than 12 weeks, then that is classified as chronic. Next slide, please. And so what's the etiology of it? Well, a lot of it is infective, 98% of it is viral. So there we're talking really about the common cold, which we're all quite familiar with. And it really only is, so bacterial only in about 2%, and that really is when symptoms have been persisting for more than 10 days. And you've got quite a sort of purulent discharge there. You've got quite severe pain and fever. And sometimes that can be after an initial sort of mild viral ERT of some sort, and then they sort of deteriorate and they've got a secondary bacterial infection there. Allergic we'll be very familiar with is the hay fever, so I'll come on to that later. But I just wanted to also flag that it can be irritant. So sometimes you may recognise in yourself that your nose starts to run a bit when you go out in the cold, changes of temperature, humidity, for some people with exercise. For some people it can be chemical, you know, someone sprayed some air freshener or hairspray or something round, or occupational. Then there's the sort of autonomic vasomotor under the other section. And I don't know about you guys, certainly if I eat a curry, I get a runny nose, and I imagine that probably comes under some of that autonomic section. Hormonal is interesting. So for people when they're pregnant, they're on the pill, or they're hypothyroid, that can make them more prone to having this, as well as medication, both official medication and street drugs such as cocaine. And the other thing is also, I think we are all aware that a lot of patients self-medicate with decongestants, but when they stop them, getting a rebound can be quite a common problem, and that's why decongestants generally are not recommended. Please, as we go along, do put any questions in the chat or put your hand up. I'm happy to take them at the end, or I'm happy to take some questions as we go along. Next slide, please. So just in your history, obviously you want to focus on how long they've had the symptoms, how often, the severity of them, and then you sort of want to understand if you think it might be infective, are there other symptoms that might suggest it? So asking about things like temperature, whether it's sort of mucoid purulent. Very important to know is whether the discharge is just from one nostril or from both, as we'll come on to later. You might want symptoms suggestive of allergy, so if they've got sort of conjunctivitis, they're sneezing, or sort of other things that may make you think more of an allergenic cause. And if someone's had this for a long time, they tend to be, a mouth breather. They might snore a lot, have very sort of dry mouth, a sore mouth in the morning. They may have problems with cough, halitosis, posterior nasal drip. These kind of symptoms could be suggestive of that. Very useful to know if they've got a personal history of allergy atopy or a family history of atopy, and certainly if they're asthmatic. A lot of asthmatic patients who suffer from things like hay fever and stuff, if you treat their hay fever, their asthma can improve significantly, so just worth bearing those in mind. As with any history, it's important to obviously know about the impact on the quality of life and if it's impacting particularly sleep, but in turn also school, work, recreation at all. Often these people have had these, they're prone to this and often have tried other treatments, and just understanding what they've tried and what's worked for them is quite important, because that will influence how you progress with your management plan. And also sometimes they will have a preference for oral or intranasal treatment, and that will be worth factoring in, but we're going to come on to treatment more specifically in a further slide. Next slide, please. So you've done your history. The next thing is to examine them, and it's recommended in NICE that you ought to probably assess temperature and heart rate just to make sure there's no signs of systemic or other more significant infection going on. And then you ought to do anterior rhinoscopy using an otoscope. So I read this recently, which I found quite amazing, but your nose is actually 4 inches long. So it's not just the bit that sticks out the front, it's the bit that sort of goes behind as well. And so with the otoscope, you do want to sort of put it quite far in along the floor of the nostril, but not so that it's sort of painful and you're ramming it full in. But I think a lot of us probably are a bit too ginger and just either don't even put it anywhere in the orifice, just looking more externally, shining a light, but really you need to go into the nose to have a proper look. And you're looking for things like purulent secretions. You'll see the turbinates there. So the turbinates, you've got 3 turbinates that go along the lateral wall. The inferior one is actually the largest turbinate, and that's generally the size of a human little finger, so it is quite big. But as you can see in the bottom picture there, sometimes they're mucus and they can enlarge if they're inflamed, and you can get quite an inflamed turbinate there. But you're looking as well for polyps. Does anyone know how to tell the difference between a turbinate and a polyp? Anyone want to shout out? So quite usefully, it is quite easy to tell the difference. And the difference is that if you were to prod, I don't know, with a swab or something, the turbinate, they're going to feel it. But with a polyp, they don't. It's not sensitive, and it does. So often they can't feel you touching a polyp. The other thing is that a polyp generally will look like a peeled grape with the skin taken off. So if you look at that picture on the left and see how sort of shiny it is, you can sort of see that the sort of surface of it is a bit like a peeled grape. So just, it can be difficult looking up the nose, knowing whether it's a turbinate or a polyp that you're looking at, but generally that's how you would distinguish between the two. Thanks, Sarab. You sort of say colour and size. So sometimes with that as well, you can differentiate between them. Although polyps can be quite small, so size isn't always, but equally sometimes you can have a polyp that's absolutely huge, absolutely occluding completely the nostril. So we've done looking for the secretions, the polyps, the mucosal swelling. You might be having a look at the septum. Is it deviated? Is it perforated, or anything going on there? And just sometimes in some people who have really bad rhinitis, it's a sort of clinical sign when they have that horizontal crease across the top of their nose. But just sometimes that can be a bit of a giveaway as well. Next slide, please. So just flagging, obviously with anything, there's sort of sometimes some urgent red flags that you ought to be aware of. I think hopefully if people had these, we would be sort of quite concerned anyway. But if you had orbital involvement, so any sort of edema or erythema, or their globe is a bit displaced, or they've got an impact on their vision, or they can't move their eye and they're having double vision, we would be concerned. Similarly, with intracranial involvement and anyone, if they'd got sort of signs, neurological signs or meningitis, I think we'd be quite concerned about that. I mentioned earlier, just to flag, that sort of, discharge from one nostril is also something just to look out for if it really is unilateral. Sometimes it could be, particularly in kids, like a foreign body that's got wedged up there and forgotten about, but you're more likely to pick up maybe some other underlying pathology if it is unilateral. We know that people often, sometimes when they've got a cold, have a bit of bleeding or crusting and things like that. But again, if that was continuing and very much unilateral, you might want to just think about whether there's some other pathology going on. If you have a CSF leak, what's quite interesting is that that drips out quite differently. It literally drips out of the nose, and it may be one side or both sides, but it will come from the tip of the nose like a tap. And so it, other sort of snot and mucus coming out very much sort of dribbles down from, the orifice of the nose against the skin. But the CSF leak will very much drip out from the tip of the nose. That's one way of distinguishing. That's obviously people who maybe have been involved in an RTA or some significant trauma recently, just so that you're aware of how to pick that up. And then the other red flag that NICE also mentions is obviously if they're systemically really unwell, but again, I think we would pick that up. Next slide, please. So this is going back to the Camden pathway that we were just flagging up earlier about how you would manage. So if someone's got an infective component, if we follow it down, I'm sorry, it is a bit small, and it's been less than 12 weeks, so it's acute, and the symptoms have been sort of less than 5 days, because most colds are going to get better after that. It really is about symptomatic relief measures. So we're going to suggest to them about, using paracetamol or ibuprofen. They could use some nasal douching, so nasal irrigation sometimes can just help to break up some of the catarrh. Sometimes if it's uncomfortable, people do use warm face packs and make sure that they have an adequate fluid intake and just generally rest to boost their immunity and fight off that virus. If, however, things aren't getting better after 10 days, or if their symptoms are sort of getting worse after 5 days and they're not improving, you can actually use intranasal steroids in a cold if they're really suffering, and they could use that for a couple of weeks or a bit longer, and that usually will help to settle things down. If, however, things are getting worse and you think that they have got a bacterial infection, that they are part of that 2%, or they've got that sort of double sickening where they're sort of getting worse and they've got the temperatures and things, then you may want to, in addition to the intranasal steroids, also add in some antibiotics, because we're thinking that their sinuses are more involved. And you can see there the first line antibiotics would be amoxicillin, doxycycline or penicillin. Second line would be your coamoxiclav. So someone said that they had a trainer recommending mometasone QGS for a week, then TGS, then BD, then OD. It's not widely used as a regime, really. I mean, I think they can just stop the steroids when they need to. You don't need to reduce them so gradually. That's quite a lot of mometasone to start with. So I think it depends how bad their symptoms are, but you could go in higher dose if you wanted to, or you could just go in BD and then just stop it after 2 weeks. So there's no right or wrong really with this. If you look at the preferred choices above, you'll see that locally beclomethasone is the preferred one, 2 sprays twice a day, and mometasone generally would be just those 2 sprays once a day and then stopping. Then you can use, third line, we have the fluticasone or nasofan, and then, or the Avamys. Now, when people have it chronically and it's really not settling, we often see quite a few referrals coming through CCAS, now known as chairs, for people where, you know, you've tried the sprays, they're not working, what else can you do? And when they see the specialist usually will just escalate it to drops, which are more potent, and discharge them with the drops. Well, we can initiate the drops. You only use them for 2 to 4 weeks, and they're on this pathway here of the drops, the betamethasone drops that you can use. And that will usually sort most people. And then if they're a sort of chronic rhinitis person, then you would often then step them down maybe to a maintenance of a spray after that. But that can be really helpful. It is mentioned there in the preferred prescribing about azolastine, the antihistamine, and I'm going to come on to that in a minute, as well as the Dimista that's got the combination of the steroid and antihistamine, which wouldn't be your first choice, but certainly when other things haven't worked is another thing that can be quite useful to try. It's important to emphasise to them that the steroids don't tend to work really straight away, so they need to use them regularly. It's a little bit cumulative, the effect, to get some impact. So I think if they think they're going to get something instant after using them, they'll give up too soon, and you just need to encourage them just to persist a bit with them. Okay, next slide, please. So as I mentioned earlier, one of the commonest reasons for drops and sprays is that people aren't using them correctly. So with the spray, they generally say you should really have a head down position, and as we saw in that photo at the beginning of the slides, the patient had their head tipped backwards. And what Mr. Mann often says is that you would use, say, your left hand to go in your right nostril and aim it at your ear is the way to, so you're directing it really at that outer wall where the turbinates are, and then use your other hand for the other one on the other side. You don't sniff hard, you just need to do a nice gentle breath in. When it comes to the drops, I mean, the logical position is that position that's got a cross by it. You can do it that way, but if you're doing it that way, you really need your head to be parallel with the ceiling. So you need to get your head really right back. Otherwise, most of what you put in there is probably going to dribble out and not get to the right place. So there are these rather awkward positions that have got a tick on the right, and that will get the drops to the right place. Now, this is in the pathway as well, so you can print this out to patients to try and make sure that they are using the drops correctly. The other thing that's also in the pathway is information about nasal irrigation or douching, how people can make up their own solution to use for that. ENT doctors are very keen on it. They sort of say it's like, you know, cleaning out your pipe work. And if you're prone to rhinitis through allergens or whatever is triggering it, really using regular douching can help to reduce the amount of steroids and other treatment that you may need. So for people who are really dogged by it, they do say that we should probably encourage them to use nasal saline irrigation on a regular basis. And they can buy their own preparations, but making their own is just as easy. Next slide, please. So this is just a photo showing patients do get into these awkward positions, but certainly just trying to encourage them, whether it's the spray or the drops, just make sure that they're using it in the right place so that it's much more effective for them. Okay, next slide. So I wanted to just talk about hay fever because we do see so much of it, and this is just a summary of some of the evidence that's out there. Apparently Allergen UK has got some really good patient information leaflets there. The link is on there, and we will be sending out these slides to people. And again, for hay fever, the nasal irrigation and also eye irrigation can improve symptoms, but also improve the efficacy or reduce the amount of other treatments that you need to use. So steroids, intranasal steroids, they are more effective. So often we prescribe a lot of oral antihistamines, but I suppose one of the key messages I want to get across today is that actually intranasal steroids or intranasal antihistamines are more effective than oral treatments. And the intranasal steroids also have a similar efficacy as antihistamines for the ocular symptoms as well. So it's not just the nasal symptoms it will help with. as is mentioned there, if you've got quite a lot of obstruction because the mucosa is so swollen, you may want to use the drops first just to get that under control, and then go to a spray. The steroids, as I mentioned, can take a little bit longer to kick in, and that's where the antihistamines, with their rapid onset of action, can be really suitable for PRN use. And just there again reiterating that the azolastine and intranasal antihistamine is more effective than prescribing oral antihistamines. So just to mention that. If you've tried those and their symptoms, are still not controlled, I've mentioned check they're using the correct technique. If they really are congested, you can use a short-term decongestant for up to 7 days to try and boost the efficacy of the intranasal steroid. But because of that rebound, we don't tend to use them a lot, and also because patients often can get quite hooked on them and then end up in this persistent thing where you can't get them off them because every time they try and stop, they're so symptomatic. So generally, we tend to avoid really the decongestants. If they've really got, watery, runny nose, you can use nasal anticholinergic ciprotropium, but we don't tend to use those a lot. And as I flagged on the pathway, sometimes using that combination spray, demister, where you use the nasal steroid combined with an antihistamine when other things haven't been working, actually can be quite valuable, and you're trying to get on top of the patient's symptoms. And in NICE, they also mention, if you're really struggling, you can also look at some mast cell stabilizers to use as well. We know hay fever is really awful for those people that suffer, and they sometimes come in and you've tried absolutely everything, nothing's working. And so sometimes you do end up having to use a short-term course of oral steroids. And so I put the dosing that you would use on there, and you would use it generally for 5 to 10 days in an adult, but only 5 days in a child. And that really is when nothing else is working, or if someone's, getting married or something and they've got absolutely terrible hay fever and sort of need something to help to cover an important life event, then that may be another time when you might consider using those oral steroids. And obviously, when you've done all that, then I think, to be honest, we've got to the end of what we can do in primary care, and you probably need to refer them to an allergy specialist who may look at testing or trying some immunotherapy or something with them if they're still really struggling with their symptoms. Next slide. So just before we move on to ears, did anyone have any questions on nose stuff? As I say, I think the information is really captured in the pathway of what to do. And I think there's a lot of people who do suffer with their symptoms. I think we can really help them to try and get better control of their symptoms, because it does impact, if you're a chronic rhinitis sufferer, it does impact you on a daily basis, really. Okay, feel free to put your questions in at any time, but otherwise I'm going to move on now to talking about otitis media. Now, by and large, with this, we're talking more about children, because it is mostly in children that get acute otitis media. So 80% of children under 2 will have at least one episode, and it only occurs in less than 1% of adults. So we do still see it in adults, but it's much more of a children's illness, really. And again, most of it is going to be caused by viruses, but you can get some bacterial causes, and if you do, it's most likely strep or heme influenzae causing it. So in an adult, generally, you'll get some earache, reduced hearing. You may even get some discharge, some otorrhea coming out of the ear canal. But in younger children, it's often not so obvious what's going on. So sometimes we know they can hold or tug their ears, although they can also sometimes when they're teething, and it can be much more non-specific, the symptoms: fever, crying, they go off their food, and just generally their sort of behaviour goes a bit off. And so often it's worth just checking kids' ears when we're seeing them when they're not that well, just to see what's going on there. Earache is a common problem, and I was taught as a medical student, and I don't know whether this is still true, but only about 50% of earache actually comes from the ear, and quite a lot can come from referred pain or from elsewhere. So I think if someone has got earache, just to be aware that it's not necessarily always coming from there. It might be that they've got a dental problem or something else, so you can get that referred pain there. Next slide. So when you've done your history, you're going to have a look at the ear, and the sort of so the one at the bottom left is a normal ear picture. And then the next one along, we've got, you know, you can see that the eardrum has got more of that sort of injection, you know, the blood vasculature. You can see it's bulging, and often they do bulge. It's called the donut sign, but it does look like a Krispy Kreme ring donut there. And you lose the light reflex. So you can see the light reflex very clearly on the bottom left one, and not so obviously then on the next two, which are good going otitis medias. You may have a perforation of the tympanic membrane, and you may have some discharge, as you can see on the far right one. You've got some discharge there. With very young children, you can't always see the tympanic membrane because it often is lying more in an oblique position. The ear canal is quite small and can collapse, so it can sometimes, particularly in younger people, be quite difficult to see it. Obviously, if there's a lot of discharge as well, you may not be able to see it, or if there's other debris there, it can be difficult. Next slide. I'm just going to mention some of these conditions because they kind of come sometimes joined up, but you can get otitis media with an effusion, so that's also known as glue ear, very common sometimes in kids who are struggling with their hearing. And you may see the fluid, as you can see in that picture there, there's sort of fluid there. There's also some air bubbles that you can sort of see there. And the red flag really to think about is if you've got a sort of persistent otitis media with an effusion in an adult, that there may be other serious underlying pathology there. So just to think about unilateral cases, particularly in an adult, is a potential red flag. The other thing you can get is when people just have this chronic suppurative otitis media, where it's discharging for over 2 weeks, and you've just got that persistent discharge there. Obviously, you would treat that with antibiotics and hope that that would then dry up and improve. But if they did have any post-auricular swelling, tenderness, obviously you'd be checking out the mastoid. It can impact the facial nerve, and they can have some drooping of their face or vertigo. Then, you know, I think we'd all be a bit concerned if any of that was happening. But just these are the red flags that can happen with that. Laryngitis is really just when you get that erythema and injection of the tympanic membrane, as you can see in the third picture there, but no other features of an otitis media. And then mastoiditis, we don't see it as much as we used to at all. It used to be much more common. But when we're examining people, we probably should be checking for it. And I know I'm guilty of often forgetting to do it. But you should be feeling the mastoid process just behind the ear, just to check it's not particularly tender or swollen or red. And usually these people are more systemically unwell anyway, so that you'd be more concerned about them. So just sort of checking that out. And then the other thing that does get missed in primary care, unfortunately sometimes, is this cholesteatoma that you can see in the picture there. It's in the superior aspect, and often it can present with just a discharge from the ear that's often painless and a bit of hearing loss. And that does need to be referred for management. So it's sometimes, if you're not sure but you're seeing something in the superior aspect, it's not responded to treatment and it's persisting, I would definitely get an ENT opinion there. Next slide. So these are the nice red flags, and obviously if someone's got severe systemic infection, we're going to think about referring them or admitting them. And if they've got an acute complication, I mean, you know, if they've got meningitis, mastoiditis, or any of these things, I think we would all be quite concerned. In children, though, less than 3 months, if their temperature is really high with an ear infection, they would recommend that we got them seen by the paediatricians. And also just actually any child less than 3 months who's got a good going ear infection, or if they're a bit older and still with quite a significant temperature, the paediatricians have sort of said that they'd quite like to be aware of these people. We will be circulating the slides. If you registered on Eventbrite, we've got your email, so you get them automatically. If you didn't register on the Eventbrite, pop your email address in the chat and we'll send those out at the end. Okay, next slide. So how are we going to manage people who've got this acute otitis media? Now, usually it only lasts sort of 3 to 7 days. And as we mentioned earlier, a lot of them are going to be viral. So again, it's symptomatic relief with some paracetamol or ibuprofen. And there is no evidence actually that decongestants or antihistamines will really help. Sometimes, though, we may want to consider antibiotics. Now, what they found, they've done quite a lot of studies, and they found that generally it does make little difference to symptoms or development of complications, actually, like mastoiditis. You think it would particularly improve them. And of course, there's, you can potentially have adverse side effects of antibiotics, and there's the big resistance issue to consider as well. So if someone comes in and they're really not too bad, I think giving them no antibiotic prescription, but just telling them that we expect this to improve. And obviously, if symptoms at any time worsen or persist, do the safety netting to get back in touch. NICE is also very happy if we want to consider a delayed antibiotic prescription and sort of say to them, look, if your symptoms aren't improving in the next few days or they get a lot worse at any time, more in the way of temperature symptoms and things, then you may want to start the antibiotic. That's also an acceptable way to manage it. And then if someone really, you're concerned that they are more unwell, or if there's someone that's at higher risk of complications, so if they've got anatomical anomalies, like they've got a cleft palate, if they're immunocompromised, you're going to maybe want to have a lower threshold for giving them an antibiotic. If they've got a discharging ear, again, you may want to give them an antibiotic. And also, if they're under 2 with a bilateral infection, you may want to have a lower threshold too. So generally, it's a 5 to 7 day course. Amoxicillin is first line. If they can't take penicillin, then it would be clarithromycin or erythromycin, and the latter one is preferred in pregnant women. If the symptoms are getting worse despite being on antibiotic for a couple of days, then they often say that switching to co-amoxiclav might be the way to go and see if that actually works. If it's not working and it's persisting, then obviously you would refer. And also if they're having persistent hearing loss or they're having persistent sort of discharge, you're going to refer if things aren't responding to the antibiotics. Next slide, please. So we do get some people who seem particularly prone to recurrent otitis media, and it's just drawing your attention, particularly in adults, just beware the nasopharyngeal cancer. It is rare, but if someone is sort of getting that recurrent infections and actually the effusion is persisting between episodes and their hearing is impacted. I know we often talk about eustachian tube dysfunction, and for many people that will just settle after a number of weeks. But if they really are having these persistent symptoms, you might want to think about whether you ought to refer. Likewise, if they've got persistent lymphadenopathy and if they're having sort of nosebleeds or nasal obstruction as well, just whether there's something there that's sort of blocking the eustachian tube and making them more prone to this. So just to be aware of that. Also, people who are having recurrent infections, if they have got a craniofacial abnormality, if they've got some abnormalities with their Down's facies or a cleft palate, again, you might want to refer them. And if they're having, quite significant recurrent episodes, I think you would want to refer. Again, remember I said it's not that common for adults to get it. So if an adult kept getting recurrent episodes, again, you might want to consider, it might be a routine referral, but you might want to just refer them as well. So most of the time referral though is not necessary. We would, if they were having recurrent episodes, you'd just treat each episode as an acute episode. If people have got grommets, then obviously you can take a bit of a swab if there's some discharge there, which might help influence your treatment options. And the sort of measures that prevent recurrent otitis media, particularly in children, smoking is the big one where they're subject to passive smoking. So maybe try to make the parents more aware of what they could do with their own smoking to help their children's health. Use of dummies has been associated with it. And also if you're feeding your kids, when you're breastfeeding or bottle feeding, if they're quite flat and supine, apparently makes them a bit more prone to it. Make sure they've done all their pneumococcal vaccinations, because we mentioned that strep pneumonia is one of the common bacterial components for otitis media. And obviously if they've got gastroesophageal reflux, then make sure that's managed appropriately, because that might help to reduce the recurrences. For adults, it's really about the smoking or passive smoking that can make them more prone, and to address that. We wouldn't use long-term prophylactic antibiotics generally for recurrent otitis media. I think if you're thinking someone might need that, then it's time to refer them and get the specialist involved in that. Next slide. So otitis externa, this is when you've got inflammation of the external ear canal. It's a bit weird. NICE says acute is less than 3 weeks, chronic is more than 3 months. I don't know what they call it if it's between 3 weeks and 3 months, but there you go. I double check that because I thought I must have typed it wrong when I was going through the slides, but that is indeed what they say. So the signs and symptoms, as we know, we see quite a lot of patients with this pain, itch, discharge, hearing loss sometimes, and sometimes the actual ear canal can be quite swollen. You can see a lot of flaky skin or eczema there, and check the external ear as well. So it is quite common. Over 1% of people will have it every year. It can affect all ages, but the peak incidence is apparently between 7 and 12 years, although I must admit I think I personally see more adults than I see kids with this, but there you go. And the most common cause in this is actually a bacterial infection, so it often is Pseudomonas or staph, and we know that if you've got trauma, and the trauma can be that cotton bud that disrupts the protective oily layer in the ear, that can cause this. But if you've got excessive moisture, so people who wash their hair a lot, people who go swimming a lot can be more prone, so it's sometimes worth exploring that with patients, or people who are prone to dermatitis anyway, and sort of getting it in their ear can be more prone. Next slide, please. So just something to think when you have got that sort of discharging ear. Obviously, is it your otitis media where they've got you know, a perforation or a grommet or something and it's discharging? Kids, be wary of the foreign body in the ear. Obviously, hopefully you'll see that when you look in the ear. If they've got earwax, that can also cause quite a bit of pain and deafness, and sometimes seem a bit sort of dischargy. So that's something to think about. We've mentioned the cholesteatoma to be aware of. We've talked about mastoiditis. I'm going to talk more about malignant otitis externa in a moment. You can get neoplasms in the ear canal that often they will sort of bleed. So I think, you know, anything that's not settling with your normal treatment, you may want to refer, but obviously try and treat first, or unless you see something with the otoscope that definitely looks abnormal in the ear. And I saw someone recently had found someone with a sort of polypus looking thing in the ear and was referring that absolutely. We've mentioned referred pain, although why you might confuse that with OE, I don't know, because the ear would be looking quite normal. Ramsay-Hunt syndrome is really important to be aware of, because you get these vesicles, but they often don't appear till a couple of days after they've already had the ear pain, but just something to be aware of. And then obviously barotrauma, particularly in people who dive or fly a lot, and then various skin conditions can make you more prone. Just going back to the people who fly a lot, though, those are probably the only people that I sometimes do recommend decongestants for. If people are really prone to sort of nasal and ear problems when they're flying, and landing is worse than taking off, then they are sometimes people who just maybe the day before flying and on the day of flying, decongestants sometimes can help them manage their symptoms if they're particularly prone to them. Next slide. So again, you know, you've got to have your red flags for everything these days, haven't you? But if someone has got extensive cellulitis or an abscess, I think we would be quite concerned, but you may need obviously to refer them. And then malignant otitis externa. Now, I've never seen this before, and we had a patient at our practice actually this year with this. So it's when the otitis externa actually spreads into the bone around the ear canal, and you know that can be sort of fatal without treatment. You need to do a CT scan really to identify that, and people who are more at risk are obviously going to be those with poorly controlled diabetes, or if they've had some radiotherapy to their head and neck, but they need urgent treatment. And they sometimes will be these people that have come back and maybe seen different people at the practice with this continuing otitis externa that we're not getting on top of. Just beware of this. They usually are unwell as well systemically. So, you know, we did talk about sometimes you do need to do the temperature and the heart rate, and just be monitoring that side of things as well, just to pick up if someone might be a bit more systemically unwell. Next slide. So you're going to assess for severity of symptoms, and again, you're going to promote self-care. So we're going to ask people generally keep your ears clean and dry. Don't use the cotton buds. If they do have eczema or something like that, that's prone sort of on the pinna and sort of going into the canal, make sure that's being treated and improve their diabetic control are all things we can do to sort of improve the management. And again, we've got paracetamol or ibuprofen for symptomatic relief, but if it's really bad, you could throw in some codeine as well. As we mentioned, most of these are going to be an infection, so we tend to use a topical preparation that combines an antibiotic with a steroid, and the common ones are Sofradex, Otamize, or Agentasone HC. We don't tend to ear swab them initially, but if their symptoms are persistent or recurrent, I find it's really helpful because sometimes you do pick up that, oh, fungal infection, should be fungal infection. When you read the books and things, they say, oh, you might see sort of white, grey or black sort of hyphae or spools or whatever. I don't think I've ever really seen something that looked really fungal, although I have seen pictures of them. But I have had quite a few patients who didn't respond to the Sofradex or Otamize, and when I swabbed it, it was fungal, and some antifungal treatment sorted them out. If it persists, then maybe it's something to do with the contact sensitivity. If the ear is really occluded with a lot of debris, then if we refer them and their ear gets hoovered out and then the drops applied, then often treatment will be more successful. And if they're in a lot of pain or discomfort, or there's extensive swelling or anything like that, then you may want to consider referral. We don't routinely follow them up, but if they are quite bad or they're diabetic or with reduced immunity, you may want to just see them once to make sure that it has settled down. But most of the patients, we send them on their merry way with the treatment, obviously with the safety netting to get back in touch if it's not improved. Now, you can get a local sort of, folliculitis or furuncle that gets infected. Often you can just see that when you look in, and they suggest that you apply a heat, maybe using a warm flannel, and it'll usually be mild and self-limiting. However, obviously, if it doesn't, they may need incision and drainage. I think that's probably beyond most of our expertise, unless it really is a tiny pustule right at the ear canal that you can just pierce with a needle to release that pustule. But I think if you're releasing that, I think most of us will happily refer. Yes, the foreign body absolutely could be causing a problem, and kids will stick things anywhere, won't they? So you're absolutely right. And sometimes you will see foreign bodies causing that in the ear. Next slide, please. And, sometimes this can be quite a chronic problem. And if it is, often the prominent symptom really is itching, and you may see the signs of scratching. Again, it can be that it is fungal that's causing it if it's a chronic problem. And these often are people who are prone to a bit more of, dermatitis, eczema anyway, maybe in other parts of the body. So it's worth sort of checking if they have that. It may not be eczema, it may also be psoriasis or seborrheic dermatitis, but just do a general sort of check if they are having a bit of a chronic problem there. I mentioned the contact sensitivity, and obviously people who use earplugs or hearing aids, maybe even earrings, and it doesn't have to be exactly in the site of right in the ear canal. It could be there you've got an earring lower down in the earlobe, but the sensitivity reaction is affecting the external ear canal. It's just worth thinking about. And there's this thing called ID reaction and auto-eczematization, and these are when you get a reaction to something. It's often an infection, but it can be like venous stasis at somewhere different to the source of it. So they might have something going on elsewhere in their body that's causing that inflammation, but actually where they get the eczema reaction could be in the ears. So just a reminder, sometimes if someone is being dogged and having quite a few problems with this otitis externa, just check what's going on in the rest of the body if they have got either the ID reaction or they've got some other dermatitis or skin problem elsewhere, could be impacting. And if you can control that, often it will help to control the ear complaint as well. And obviously, if we're stuck, we've always got the option of referring, and some people who really are problematic absolutely need the support of the specialists. Next slide. So my last topic is earwax. Now, Earwax can cause a whole range of symptoms, so from hearing loss, tinnitus, pain, all sorts of things, itching, smelling discharge. It can actually make you cough and feel dizzy as well. Next slide, please. So the thing to do is, a lot of practices have a patient leaflet, and it probably is worth thinking about having one. I'm sorry I haven't got one to hand here to share, and that's maybe something we should think about, but I have seen them on various practice websites about how to look after your ears, and that you can signpost patients to. And just to remind them that, you know, they shouldn't be using anything to really try and remove the wax, that they should be using olive oil or other softening drops. They don't need to be warm before use, and use them for up to 2 weeks. Sodium bicarbonate drops is another alternative. Some people find them very effective, but some people do find they can dry the ear or be quite irritating. So sometimes oil works better for some people. Better if they use a dropper and they lie with their head on one side for a couple of minutes. And if they're prone to it, to prevent the recurrence of build-up, to use that you know, regularly, once a week or whatever, just to prevent that build-up. Now, you would think with wax there wouldn't be a red flag, but according to Mr. Mann, there is. If you've got wax in the attic area, so that superior aspect of the ear canal, just think, could it be a cholesteatoma? So if, you know, usually wax isn't just stuck in the top attic area, but if you have got something that looks a bit like wax there, then just think about that. Next slide. So the big question really, isn't it, is to irrigate or not? And I know certainly at our practice we constantly have this debate on this. You know, drops do work in the majority of people. So I think making sure absolutely that people are using the drops properly and consistently, because that is going to work most of the time. Now, NICE says that if that doesn't work, that we should not offer patients to do the manual syringing. So that's when they can buy these things off Amazon or whatever. You know, Otex do one that they can remove the wax themselves. However, certainly some consultants think it's probably not harmful. It works in about 50% of patients, and so, you know, I know some practices do recommend patients using them. I'm just flagging that NICE say not to, but I'm not sure on what they've really based that evidence. Some practices do offer irrigation after, you know, for those who've tried to use the drops and it's failed. We've got the microsuction clinics. The problem with them is the waiting times are long, and I don't see that changing anytime soon as a result of COVID. So it can be like 6 to 9 months, the waiting time for our local ones at the Royal Free and Royal National Ear, Nose and Throat Hospital. So if you've got a really symptomatic patient, that's a long time to get it sorted. And I know sometimes patients are directed to go privately as another option. It generally costs something like about £150 or something to do microsuction privately. Maybe someone's found a cheaper clinic. If you do, let us know. So these are the options. I think what practices do is different, and obviously it's up to you what you do at your practice. But, you know, earwax, as we know, is something patients, you know, commonly complain of and is quite an issue. But by far the majority of them ought to be able to, if they use the drops properly, that should really sort it.